Okay, and here we go with Joe's meds. This is lesson 4, part 1A, the medications. So, as a refresher, the equation blood pressure equals heart rate times stroke volume times peripheral resistance. We're going to think about which part of this equation the drug is going to affect that we're going to think about using, and we're going to consider over time with this patient and others that we're going to look for a combination of effects so that it's like juggling balls in the air. If we can reduce heart rate, we will reduce the blood pressure. If we do reduce stroke volume, we reduce the pressure. We reduce peripheral resistance or decrease the vascular tone and increase vasodilation, then we can decrease the blood pressure. Let's start in the kidney and with diuretics. This is a cartoon of the glomerulus, of which there are, of course, many in the kidney. And we're going to focus on the thiazide diuretics because they are first line in the guidelines for treatment of hypertension. We'll start with hydrochlorothiazide because you'll hear it most commonly referred to, and it is a drug that is found on the $4 list. I will mention that chlorthalidone, which is another diuretic, also older, but not as commonly used, is a little more potent. And when I went to a conference this past year on an update on treating hypertension and especially cases that are tough to treat, the speaker recommended considering chlorthalidone for these kinds of patients because it had a little more potency to it. I wanted to call your attention to the additional note I've added to this slide about potassium loss in the case of thiazide diuretics. While it's not their major electrolyte that's lost, there is a potential, especially when we get into higher doses, and it is something we want to monitor. So often these patients have serum electrolytes monitored through a metabolic profile or a comprehensive metabolic profile, which is ordered as laboratory testing. In just using, again, our hydrochlorothiazide or HCTZ in terms of dosing, we take a look at starting these folks, normal healthy adults, younger adults, at 12.5 or 25 milligrams daily, usually taken in the morning. It is a diuretic, so we do have to keep in mind that the patient is going to need to have access to restroom facilities if they're in public. And so working people, sometimes this is a barrier for them. And I've had patients, many of my patients work in lower paying jobs in retail, and it is very difficult for them to adhere to this schedule because they're only allowed to leave the work area every 4 hours to use the restroom, so they have trouble maintaining compliance with this drug. I do want to also note that in Hippocrates, you'll see that the dose can go as high as 50 milligrams. It's kind of given as a range. And you'll see sometimes that providers will push the patient up. When we look at data about what kind of antihypertensive effect that additional diuretic has, it is fairly minimal, between 25 and 50. Therefore, we like to think about stopping at 25 for most, and especially for elders. I don't want to go any higher than 25. Also, for the elders, I do want to start very low, sometimes even 6.25 milligrams, certainly at 12.5 milligrams, because as any blood pressure lowering drug will do, but particularly the diuretics, dizziness is a problem with these meds, and in the elders, you certainly don't want to invite further problems with mobility or falls, and thus mortality and morbidity from secondary to fractures, etc. The second major class of diuretics I want to talk about here are the loop diuretics, and we have furosemide down here below in this part, and it's called the loop diuretic, working at the loop of the glomerulus. And in this case, furosemide is probably not going to be seen much in your hypertension guidelines, but more in your heart failure guidelines, so I do want to give it a nod here. It is a great drug for taking off fluid. It's an older drug, but it does reduce fluid overload much more quickly and effectively than the thiazide diuretic. As you see, of course, a lot of electrolytes are lost with the use of this diuretic. It's usually dosed once daily, although you will read in Hippocrates that you should dose it twice daily. Why is there a difference there? This is practical. Most people really cannot tolerate an evening dose of such a strong diuretic because it will make them have to pee all night long. And getting up several times during the night, being disruptive to sleep, of course, is not great, especially again in an older patient who already has mobility issues and risk of fall. So dosing ranges between 20 and 80 milligrams in a day. We found that if you give it once a day, you can get good diuresis. And what we do is advise patients who are taking high doses to take their doses early as they can first thing in the morning, and to not plan to go anywhere or do anything for a few hours until they're kind of diuresed, and then they can move on with their day. We talked in class about the fact that this is one of the ototoxic drugs, or drugs that hurts the cranial nerve 8, so that it does add to the problem of deafness and age, but except for also having the diuretic effect of dizziness and low blood pressure, that is kind of one of the major problems with this one as far as side effects. I'm not really going to talk about the potassium-sparing diuretics. They do exist. They're used often you'll see it sometimes in a protocol with a patient who has failure. Of course, as it says, that means that it does not, it actually keeps potassium in. It is used in other applications for other reasons, such as polycystic ovary syndrome, for complex reasons I'm not going to go into here. It's important to kind of understand the renin-angiotensin system, which is really a homeostatic system in the body, before you start to think about drugs that affect this system. This is fairly simplistic, really, of a very complicated system that, as you can see, kind of following along the pathway of starting with the kidney, producing renin, over here to angiotensin 1, then through the lung, angiotensin 2, and then the antidiuretic hormone kind of coming down to the kidney, kind of circular. Bottom line is we're looking at smooth muscle vascular tone overall, and these these systems create this homeostasis and allow the smooth muscle and the vasculature to maintain blood pressure. You know, we think of blood pressure as bad, but blood pressure, of course, is necessary to maintain life. So a bit of review, not necessarily to understand every step along the way, but to appreciate its effect on the body. And here we see where the drugs that we use can impact this system along the way. We'll start with ACE inhibitors, angiotensin converting enzyme inhibitors, that is, or ACE inhibitors, or ACE-I. Our model drug is lisinopril. It is one of the more potent ones and very effective, and also on the $4 list. And it is one of the ones that works just fine if taken once daily. It works here at this point in the system and blocks the actual angiotensin 1. These drugs are dosed, again, we start low, sometimes 2.5 milligrams or 5 milligrams. We can move them up. There's quite a bit of range with these drugs. They're fairly well tolerated. These are the drug you've heard of. Your patients may complain of having an ACE cough, a dry cough that is sometimes bothersome to patients. Other times they don't seem to mind it. And we want to, we can switch them. Sometimes the ARB, the angiotensin 2 receptor blocker, won't cause the cough, and sometimes we can use that. Keep in mind that when we ever talk about ACEs, it's ACEs or ARBs. We do not ever combine these two in one drug or give a patient a drug from each class because they're really working in the same system, and we don't want to overload that. So again, these drugs work by reducing the peripheral resistance by virtue of blocking these important steps along the angiotensin system. I do want to mention that the recommendations for those persons who are black do not include the use of ACEs and ARBs. And it doesn't mean that we never give them or that it's contraindicated. It's that the effectiveness is lower, therefore we start with other drugs. Now, calcium channel blockers, which are one of the drugs that we consider closer to first line with a black population, such as verapamil, nifedipine, amlodipine, are in their various subgroups of calcium channel blockers, and you can read more about that, but they all have these basic inhibitory effects on cardiac functions, thus reducing heart rate, conduction, and contractility. So that hits actually a couple parts of the blood pressure equation in terms of reducing heart rate, as well as reducing that force of contraction, or even though there might be the same amount of volume, the stroke volume and the pressure pushed out there is reduced by all of this. These are drugs that we go to. This is our go-to drug when we want to really reduce the blood pressure very fast. These are things we use in emergency settings, but even in a primary setting, sometimes if we know we have a very high blood pressure, even though it's not malignant hypertension that needs to go to emergency room for immediate treatment, we know that we want to get that blood pressure down quickly. This is going to be the drug of choice. Sometimes it's got to be an older drug like verapamil that has to be given more than once a day. That can be bothersome for a patient, but at least to get that blood pressure down quickly. I'll also note that a commonly used drug, amlodipine, excellent drug for primary care, well tolerated by most populations, does have a funny little side effect of creating a non-pathologic form of peripheral edema, kind of a very slight peripheral edema, and we'll talk about that a little bit more later too. Now, beta blockers are, again, we said they are kind of have moved to the bottom in days gone by. They were kind of one of our first drugs, and we used them a lot. They too work in reducing the force and rate of the heart, and they also have a nice effect on reducing renin secretion, which is a nice additional effect. Keep in mind that you have beta blockade, you have the beta 1 and beta 2 fibers in the sympathetic nervous system. And beta 1, if you can remember, you have one heart and two lungs, so beta 1s are affecting the heart primarily. Now, beta blockade, beta 2 receptors have more to do with vascular resistance, which sounds crazy to give a drug for blood pressure, but that's going to actually increase vascular resistance, but that effect is fairly small compared to its combination with beta 1 with decrease of force and rate. Unfortunately, if we're blocking both beta 1 and beta 2, we hit the airways with increased airway resistance, and we have to be careful of that with patients, particularly with chronic obstructive lung disease, COPD, or asthma. So there are drugs that are selective beta 1 blockers, like atenolol, and that's an older drug, and there's some other newer formulations. And then there are non-selectives, such as propranolol, which will hit the airways as well. However, it's interesting that propranolol is one of those drugs, and I think it might be because it does increase vascular resistance, that we like for migraine prophylaxis. And so you will see these are sometimes drugs that we have a 2 minutes in 1 approach by using. So we may not see them as a primary, but we'll see them as a secondary medication. So that's the end of this slide presentation, and now you'll go on to part 2. of lesson 4.